Good evening, everybody, and once again, a very warm welcome to the 30th episode of 4D program. Today, actually, is a very special episode, and it's a very special episode because, in commemoration of the Women's Day, which was on 8th of March, we are going to be having a very, very special episode regarding women and diabetes. And to present this today, we have none other than Dr. Beena Bansal, whom we know not only as an endocrinologist, not only as a founder and director of Door to Care and Endocrine and Diabetes Clinic in Girgaon, but most importantly, a person who is very empathetic, a person who really believes that women are special and need more specialized care, and a person who really is having great interest in narrative medicine, medical humanities, and behavioral sciences in chronic care medicine. So, who else but Dr. Beena Bansal to take over from here today? Not only a great endocrinologist, but a very close friend too. Over to you, Beena.
Thank you, Dr. Shaila. Hello, I am Dr. Beena Bansal. I'm an endocrinologist in Gurgaon. And this Women's Day, we are discussing a very important topic, that is women and diabetes, how diabetes affects women and how being a woman affects diabetes. Can we have the slides? Yeah. So we know that diabetes is a silent killer. Diabetes is called as a silent killer. Killer is a very scary word. What we mean by this is that having diabetes doesn't present with any symptom, but it does increase the risk of early mortality, and that risk is much higher in women as compared to men. Um, why is that? There are still reasons which are being explored, but we understand that the risk of heart disease is increased in women with diabetes much more than it increases the risk in men. So the proportionate increase in women with diabetes is at least 4 times as compared to non-diabetes. And the outcomes after heart disease are also higher in women. So the prognosis after having a heart disease is much worse if it's a woman as compared to men. Also, other complications like blindness, kidney disease, and diabetes related distress and depression are much higher in women as compared to men. And that is why we are discussing this topic on how to address these increased risk. So, type 2 diabetes is a prevalent disease. Even more common is gestational diabetes. In women, we know that all women have to undergo various stages in life, and pregnancy is a very important stage in the life course of a woman. And 2 to 7% of pregnancies may be affected by gestational diabetes. Some ethnic groups and races, for example, Indians, are at much higher risk of gestational diabetes. And after delivery, many of them may return back to a normal glucose tolerance. However, having gestational diabetes increases the risk of developing diabetes in next 15 to 40 years. Half of women diagnosed with gestational diabetes will develop diabetes in next 15 to 20 years. So it is a risk factor for future diabetes, and therefore it is an important condition to treat and address. Why does gestational diabetes occur? During pregnancy, there are certain hormones which lead to insulin resistance, and therefore the pancreas has to work harder to make more insulin. However, if there is some pancreatic insufficiency, that may be unmasked during pregnancy, and that presents as gestational diabetes. There are several risk factors for this. For example, if the weight is high, so obesity is one of the risk factors. Age is one of the risk factors. Age more than 30 years, the chances of having gestational diabetes increases. Or if there is a previous history of GDM, history of polycystic ovary syndrome, and certain racial, certain ethnic groups, for example, Asians or Hispanics, Africans, and Pacific Islanders, they have higher risk of gestational diabetes. How do we screen for gestational diabetes? In India, the advice is to screen all women with pregnancy as soon as we find out that they are pregnant. So during their first antenatal visit, or as soon as a woman has pregnancy, glucose levels should be checked. The way to check glucose intolerance is to do something called glucose tolerance test, in which the blood samples are collected at 0 minute, 60 minutes, and 120 minutes after 75-gram glucose. If the test is normal, then a repeat test is done at 24 weeks, because 24 weeks onwards, the chances of having gestational diabetes increases. So this has to be done in all women as soon as she's diagnosed with pregnancy. And if it is normal in the first test, then again a repeat test has to be done at 24 weeks. There are other special considerations in women with diabetes. One is cardiovascular disease, which we discussed, that the risk of heart disease is higher and the mortality because of heart disease is higher. Mental health issues. Diabetes in women leads to more mental distress and depression. Chances of infection needs to be addressed. And also, women with diabetes especially should always have a planned conception. Therefore, contraception has to be adequately addressed. Fertility has to be discussed with her, and the fact that they may have a decreased life expectancy and they have a high risk of coronary heart disease, which is partly explained by loss of cardioprotection in women with diabetes. Of course, there are other risk factors like obesity, being postmenopausal, and of course, diabetes is one of the risk factors. There are a lot of medications which are available apart from diet and exercise, which are always important to reinforce, because leading a active lifestyle and making right food choices is the first step towards improving health. There are several new medications which help in not only good glycemic control, but they also help in reducing risk of complications, especially cardiac complications. And therefore, it is important that early in the course of diabetes, we should aggressively manage glycemia and these risk factors. So, early initiation of combination therapy is what is recommended. We no longer use a stepwise approach, but from the very beginning, it's a good idea to use a combination of drugs which can synergistically act and control blood glucose effectively, not allowing the A1C to remain high for a long time. And one of these combinations, which is SGLT2 inhibitor and DPP4 inhibitor as a fixed drug combination, is a very convenient choice because, number one, it reduces pill burden because two tablets are there in a single tablet, and that improves adherence and compliance. It also takes care of other issues apart from glycemic control. For example, this combination helps in reducing body weight and reducing blood pressure. These are some of the extra glycemic effects. It addresses different pathophysiological mechanisms in diabetes. That is, it improves both insulin resistance and beta cell function. And it's a safe medication to use because there is no increased risk of hypoglycemia. And the glycemic control is sustained over a long period of time. And it is overall a very cost effective medication to use in women with diabetes in India. With that, I'll end the presentation. Thank you.
Beena, that was a fantastic presentation, which I just heard about, women and diabetes. I have some questions, some very burning questions, Beena, which keep on cropping up at all points of time, when we are talking about women and diabetes. I wanted to understand from you is that how significant do you think is the prevalence of diabetes in women in our country? I mean, we are increasingly talking about India being the diabetes capital of the world. How much do women, if we talk in terms of percentage, rural, urban, how much does the problem actually pertain to women also?
See, as the diabetes increases overall in a population, simultaneously the prevalence of diabetes in women is also going to go higher. And same is the case in India, because overall, as the diabetes percentage increases, more women with pregnancies are affected by diabetes, which is in the tune of, depending on what diagnostic criteria we take, 10 to 20% in various studies. So, which is a huge number who are not only themselves at risk for future diabetes, but it puts a whole new generation, the next generation, also at risk for diabetes. So this is what is fueling the whole epidemic. We're talking about next 20 years, 30 years, and the next generation, because there is an intergenerational transference of risk through women. So therefore, it becomes really relevant.
I totally agree with you. I mean, Beena is very aptly putting across the transgenerational risk, which we are talking about nowadays increasingly. A lot of importance being given to mother's health, so that you are actually going to be able to stem this epidemic that we are facing, because it is the mother. It's almost like the mother the health of the child is decided in the womb of the mother. It is actually as, not as simplistic as that, but yes, a major contributor to a future generation's health is decided in the mother's womb. Beena, do you think diabetes affects women differently than it does men? Do you think we have certain symptoms of diabetes which are unique to women, or would you really, sort of look after both the genders with the same yardstick?
So yes, biologically, but diabetes affects women a little differently. For example, recently there is a lot of discussion on how cardiac disease presents much differently in women than in men, and this is such a recent thing which we have noticed only in last 2-3 years. Before that, and I remember a case, actually an elderly woman who was roaming about at different centers with symptoms of fatigue, just fatigue, being investigated for everything. Finally, after 3 months of just roaming around, someone caught that she actually had coronary heart disease, and then she was treated for that, and her symptoms improved. And this is because we did not understand that this is a complication of this is a different presentation of heart disease in women with diabetes. So having said that, we can't change the biology. We can't, women are women, men are men. So there are differences. There are differences in symptoms. There is higher mortality in women than in men. But whether all of it is attributed just by biology, or is it also psychosocial? I mean, sex and gender are different things. So maybe because we are women, the risk is higher. But also it is perhaps because the symptoms are dismissed more often, because access to care may not be adequate, which we understand. In rural populations, access to care may be very, very poor. Elderly mother at home, not everyone would take them to the clinic. And when it comes to decisions, women do not proactively go out. They'll take care of others, but they may not proactively go out and do their health checks. So one of my friends in big health institute where I used to work, he told me there is a surprising, they were just analyzing executive health check data, and he said 90% are men in that. So that's so strange. This is a routine health check, and 90% of them are men, because they were trying to collect NASH data. So that kind of highlights, and that is urban, high class population. Most men are going for routine checks and women are not. So just to say that we can change this, we can change these norms. We need to go out and take care of our health, go for routine checks, proactively. Any symptom, go and talk to the doctor. Maybe they are shy in complaining as much. That is a problem again, I think, in women. So these are small small things which make a huge difference in the prognosis. Yes.
I totally agree with you, Beena. I think it's a whole spectrum of
Mm.
various reasons why not only do women behave differently as far as diabetes is concerned, and as you highlighted, very very important social aspects as to why women are not looked after maybe as much as the male counterparts. Very very relevant points which you've just made, including the fact that maybe symptoms are not looked at that seriously, and maybe it's just that you just don't complain, you assume that it is just part of maybe the aging process or part of being a woman. I totally agree with you on that. Albina, do you think somewhere it is women themselves who are not very aware of the risk of diabetes, or is it that they sort of brush it under the carpet? What could be the reason, especially when you're looking at our rural population? I mean, you just spoke about a very classically urban population, highly educated. But when you take it down to the rural population, do you think the problem still multiplies manyfold?
Yes, yes, there is an intersection of poverty and gender. I mean, the poorer women, poverty really hits women more than men. That we understand. If there is a choice, the men would be taken care of as compared to women. That's simple as that. Secondly, I think the norms are so deeply ingrained that we do not realize, because they have always, from a childhood thing, they have understood that the boys are cared for more. We see that even now. I mean, whatever said and done, that's the scenario in the kind of sector you're saying. If like simple things as food preferences, like the male members are they eat first, women are going to eat later. Small small things that is so deeply ingrained that they don't realize that they're not taking care of themselves. It's very difficult, because those are reinforced in the families, at schools, even after marriage it multiplies huge fold. They have to take care of others. I mean, that's already
It's supposed to be part of
known. It's
your persona, I guess. I mean, where you're just supposed to look after everybody. You're last on the list.
yeah, it's difficult for them to even understand that there is a different possibility there.
Yeah. I totally agree. And I think it's just perpetuated, Nabina. It's just perpetuated across the generations, kind of a thing. I really understand what you're saying. When you talk about diabetes, Bina, do you think it affects our hormonal balance, overall health differently? You just mentioned about cardiovascular disease. You mentioned that women with diabetes are at a higher risk of cardiovascular disease. Are there any other diseases they should be taking care of? They should be thinking about when they're looking at at their health.
Yes. So definitely, the whole reproductive cycle lifespan of the woman, starting from how that affects their menstrual health and pregnancy risk, menopause. So all these different stages are affected by diabetes. So young women has had to be counseled about having always a planned conception, taking care of contraception. That's there. So diabetes, usually women with premenopausal women are at lower risk for heart disease, but that benefit is lost in women with diabetes, and even in early age groups they may have heart disease. So these are some of the differences which we see. Even younger women having higher risk of diabetes, so the protection is lost and it becomes equal to men. Um, that's one difference.
Bina, what is your opinion regarding the intersection between diabetes and pregnancy? One, we have the pre-gestational diabetes group, which we all know, with the high, I mean, with us, sort of looked after very differently. And one, we have the gestational diabetic, which we know is also actually a window of opportunity to prevent further diabetes. When you look at the entire spectrum of reproductive health and diabetes, do you think the incidence is increasing in our country? Do you think that with further worsening of obesity and with further worsening of lifestyles, somewhere the entire problem is sort of multiplying by the day?
Yeah, definitely. So not just gestational diabetes, but pre-gestational diabetes we see so often now, that women with diabetes, because number one, pregnancies are being planned later and later in life, and secondly, weight and overall lifestyle impact on the risk of diabetes is going up. So both these factors have are now contributing to a very high a good amount of people who already have diabetes. And um, women who already have diabetes, they need to be screened for complications like eye disease and kidney problem before going for conception. So those are additional things which we have to take care. Unplanned pregnancies are still common in women with diabetes. So if pregnancy, we can ensure a safe journey during pregnancy, but on the other hand, not adding additional burden on the woman, because what happens is, there is this stigma, women with diabetes, marriage and pregnancy, there is still a lot of, so we don't want to pass on the message that there is any difficulty in planning pregnancy. I mean, uh, there are precautions which we need to take, but women with diabetes are very well able to conceive, and healthcare has improved so much that I think most pregnancies are successful. Only thing is they need to go to a healthcare specialist and take care of themselves properly. That's the only requirement, I suppose.
I think that's a very important message you're giving across, Bina, and I think that we should really re-emphasize on this, that women with diabetes can conceive. They just need to see to it that they have their target HbA1c on target before they plan any kind of conception, so that we do not have any kind of congenital abnormalities, any kind of other metabolic issue arising during pregnancy, along with this diabetes. And I think it's very, I mean, the message is a very strong message which you're giving, because we need to be careful with these messages when we're talking to patients, especially as clinicians, as physicians, that we don't give the message that because often, as you very rightly said, patients delaying pregnancies, it happens that there's a family coming to you, there are patients, I mean, coming to you and asking, oh, is it okay if we get married to this person because a person has diabetes?
Yes.
And that is a very big issue. So I think what you're saying is something which is very, very important message that you're giving to all our physician friends who are listening on to us, that we need to be careful of the language we use when we are talking to patients, and not only to patients, to their relatives, especially to new families, new relations, so that we are able to walk that tightrope. I mean, very, very important pertinent message. I hope all the listeners really taking note of what Veena just said, because I think that's really very important and very, very relevant to today's world. When we talk about therapy, Veena, do you think there's any difference in the therapy we offer to our patients, irrespective of gender? Would you talk in terms of we have newer OHAs, we have GLP-1 receptor analogs, we have insulin, newer insulins? Would you really call either one safe or unsafe? How would you really look at medical care as far as patients are concerned?
So, so we have this whole spectrum of new medicines, and of course, all of them are available for women. There may be differences, gender differences in response to treatment. We still are new in that area, and mostly the choice, women versus men, are not yet different, except that if they are planning conception, then we have only choice of metformin and insulin. If they are not, then we have other drugs as well. And hopefully we'll have more and more safer drugs in pregnancy also, with increasing number of trials in women. So I think research in focusing women, and now that the criteria is to have women representation in research, that is important to figure out if there is a difference in response to different drugs. But I think as of now we use various drugs similarly in men and women. Clinically, we may find some differences, like gastrointestinal side effects are slightly higher in women. Even genital infection, like I feel a little higher in women as compared to men. So those things have to be counseled about. But yes, these new drugs have improved management quite a lot. They take care of weight, blood pressure, as well as, so beyond glycemic controls, we are able to manage health in a better manner. Cardiac risk goes down with the advent and use of new molecules like GLP-1 receptor agonist and SGLT2 receptor inhibitors. Plus, the fixed drug combinations have improved medication compliance, which is considered one of the issues with women. Somehow, women are more reluctant to take more medicines. Probably they find it very difficult to fit in that taking medicine into their day. I think most women say that बहुत सारे काम है सुबह, they keep forgetting taking medicine. Somehow that is a difference there in men and women, which needs to be understood better, why there is a difference and how we can help them with that. So probably having these, simplifying their regimes, giving them easier things to follow and not very complicated lifestyle management and complicated diet, drug advices. So simple uh, things which they can easily fit into their lifestyles. Of course, we have lots of choices which are equally there for men and women. Noticing small differences while taking care of them, I think those are things which we can do.
I always learn something when I speak to you, Beena, and I'm sure this audience also has learned so much more, because I think these small nuances which form a part of daily living, we somehow tend to overlook it in a busy consultation. We just don't realize it. I mean, when you're looking at a patient sitting across you, I don't think often we remember that, oh, I mean, this patient is a female patient, maybe needs to be handled a little more differently. Maybe we need to understand a regimen a little more closely so that we can help her a little better. I think these are very, very small, apparently look like very, very small areas where we can make a difference. But in the bigger picture, they would make a very big difference, because you would then be able to motivate a woman to actually take care of herself. So, I mean, as I said, I always learn something. Great. It was really fantastic speaking to you, Beena. I'm sure in this special women's episode, everybody has really learned a lot more and is going to be a little more sensitive when they're dealing with their female patient sitting across them, and try to understand better what is it that makes the difference, and in what way we could help improve the quality of life of the woman sitting in front of us. Thanks a million, Beena. Thanks a million for being here with us.
Yeah.
Pleasure.
Thank you so much, ma'am.
Pratik, are we
Oh.
good?
Yes, ma'am. Totally perfect.
Absolutely fine? Okay.
Yes.
With Beena, it has to be perfect. I wouldn't worry about it.
Dr. Shella, how nicely you